So hello everyone, I'm Maria Hesami. Let me share the screen. As you know, I'm a dermatologist and my office is attached to hospital Scarborough General. So this is, I'm going to share my slides. So I'm going to talk about what is new in dermatology. And I try to make it relevant to the hospital work and your work. I have to warn you that there are slides that they are not very pleasant. So if you are having lunch, it may a bit disgust you, but I'm sure you have seen this. And a couple of patients, they are hospital patients. Even currently, I got their basically approval to show their pictures, but you may know them. So these are my disclosures. My objectives are reviewing new advancements in dermatology and review some of complications of new therapies, because first you have to be aware of these drugs, and second, you have to basically know what to look for when these patients are admitted, and overview a few difficult and challenging cases that I had recently, basically. We have a lot of biologics. In fact, as a dermatologist, we are very lucky that we are practicing now compared to 20, 30 years ago. At that time, we didn't have a lot of options like to treat like extensive psoriasis or atopic dermatitis or a lot of skin conditions. And at that time, even sometimes, like if we had 40% improvement in case of generalized psoriasis, we were happy. Like 20 years ago, when Enbrel came, like it was like PASI 75 was 40%, and we were happy. With methotrexate, PASI 75, and that's an indication and a marker that we know how much improvement we've had in the like since starting the treatment. So if they're 75% better, then we say like PASI 75. Basically, with methotrexate was in the best time is 30%. But now we have a lot of fabulous drugs, and they're relatively safe. They are even less immunosuppressant than methotrexate, and even less than prednisone. So these are the class of drugs. I don't have any intention to go in detail of any of them, but anti-IL-23, we have Skyrizi, risankizumab, we have Ilumya, tildrakizumab, we have Tremfya, gazelkumab. And then anti-IL-17, we have brodalumab, which has a bit of different mechanism because it works on receptors. We have Bimzelx or bimekizumab. We have Taltz or ixekizumab. We have Cosentyx or secukinumab. Anti-TNF, we still have like Humira, Cimzia, Remicade, Enbrel, and the biosimilars for them. Cimzia is the only one that doesn't pass through placenta, is the safest for patients that they try to conceive. We still have anti-IL-12/23 Stelara, but we also have biosimilars that soon they're going to be approved. We have biologics for atopic dermatitis, like anti-IL-4/13 Dupixent and anti-IL-13 alone Atralza. For atopic dermatitis, besides biologics, we have JAK inhibitors, and for psoriasis, we have TYK2 inhibitors, JAK inhibitors, we have OX40 is coming, and we have anti-IL-22, which I'm not as how much effective is that. For alopecia areata, we have 2 JAK inhibitors that they are right now, none of them approved in Canada, but soon be approved, and we use them off-label, ritlecitinib and baricitinib, and for vitiligo, ritlecitinib is coming. Some of these JAK inhibitors, they're familiar names for you, especially if you are in hematology or rheumatology. They've been around for a while. But we have more and more JAK inhibitors coming, and they're getting more targeted toward mechanism of the drug for that particular conditions. So for psoriasis, still, like our first line is anti-IL-23 and anti-IL-17. Depends on joint involvement and depends on comorbidity. We may prefer one over the other. Anti-IL-23s are less often injection every 2-3 months versus anti-IL-17s. Bimekizumab is every 2 months. Still doesn't have indication for joints, but it's an amazing drug. It's so fast, so quick. But bimekizumab gonna probably have joint indications soon. We have also Taltz and Cosentyx that they work well for joints. But if there's any family history of IBD, Crohn's, ulcerative colitis, we are a bit cautious with the anti-IL-17s because they may actually trigger that, But anti-IL-23s are very safe. They are basically like they give probably least of immunosuppression. We still do TB tests for every patient. I do quantiferon gold and TB skin tests for every patient of mine. But with these drugs, even in Europe, when they were doing the trials, there was no requirement for the tuberculosis test because it's not like anti-TNF that they open the granuloma and release the mycobacteria. So they are much safer drug when it comes in the context of infection, especially TB. Still, we warn our patients with anti-IL-17, as I said, we warn about IBD, Crohn's ulcerative colitis. Still a bit early to talk about cancers, but even the studies with anti-TNF, they said they are, if not protective, they are not increasing chance of cancers. But any of these drugs, if we want to start, we ask oncologists whether they are okay with it or not, or if we want to continue. Psoriatic patients, with the load of inflammation they have, they're more at risk of a lot of conditions, including lymphoma. So that's something to consider, when we want to start these patients, we warn them, we have to check, but also we don't do a lot of blood tests and monitoring for anti-IL-23 and 17. We just ask to check with their family doctors. So if any of these markers, if the blood drops, if they get, any sign of leukemia or lymphoma, we have to be cautious, but not necessarily because of the drug, because overall they are more at risk. And even methotrexate probably it increases more chance of cancer. Yes, there is a relationship probably with biologics and skin cancers, but again, if patients go on methotrexate or light therapy, also that increases that chance. And majority of skin cancers, they are no big deal, but we recommend patients on biologics to be checked yearly to pick up their skin cancers earlier. When it comes to melanoma, we are still cautious. So if patients, they have active untreated melanoma, we may not start biologics unless the oncologists give us the green light. One of the challenges that almost every day I have in my practice is hidradenitis suppurativa. The routine is like, it depends on, we have Hurley 1, 2, 3, Hurley 3, they have a lot of scar and inflammation. Hurley 1 is mild, like in papillary acne, and there are certain sites that they are more involved. Generally, we start with antibiotic general measurements. We have to address metabolic syndrome. Sometimes in some patients, we give metformin. We have to basically, for women, if it's related to their hormones, sometimes we give spironolactone. So sometimes we give doxycycline. Generally, we start with doxycycline for 3 months. And if patients are doing better, and we use topical, clindamycin or benzocaine or something like that, and ask to lose weight, low glycemic index diet. But if they're really, and avoid tight clothes. And if they're not really doing better, one option that's had been around was Humira, or now biosimilars for adalimumab. In in my experience, like 30% of patients, they get better, and 30% they get, they say that it still comes, but not to the point that they need to visit emergencies. This is really a condition that affects quality of life. Not only it's painful, it affects, well-being, it affects intimacy, it affects, social well-being. So we are still looking for the it drug. We still don't have that it drug, So Cosentyx, which is anti-IL-17, recently had 2 studies, Sunrise, Sunshine, showed some effectivity. And some of my colleagues tried and say, like they tried for patients that they failed adalimumab. However, we are cautious because it's anti-IL-17 and we see more HS in the context of IBD. So if a patient again has family history, or we have question, because sometimes it's hard in perineal area or perianal area to know, is it HS or IBD? So sometimes in those cases, we have to investigate more and we make sure that we are using the right drug. Bimekizumab, again, another anti-IL-17 we use off-label for Cosentyx. It didn't get CADET approval yet, so we may not have it available for public. JAK inhibitors and small molecules, and there are more and more studies coming. But as I said, we're still looking for the it drug. My experience is if we see this condition, we have to treat it early. And it's one of those things that we really need multidisciplinary team. It's combination of metabolic syndrome, surgical thing. Sometimes, like majority of them are depressed. Majority of them, it affects their mood, their work, their social well-being. So we need a lot of hand-holding. Like whenever I go to a room that an HS patient is there, generally I can't get out earlier than half an hour. These are difficult cases, and the awareness, because if like a lot of these patients start to get this condition in teenage years. So, and we have a lot in our, Southeast Asian community. We have a lot in our, basically, in Afro community, like we see worse cases in those ethnicities, or at least I see the worst cases. So maybe I'm a bit biased because we have plastic surgeons at our hospital, and they send a lot of their patients to me after they do surgical things. But since I gave few rounds to emergency doctors, now they pick it up, and I get a lot also from our emergency doctors. So this is the condition that we need awareness. We have to start early treatment. We have to address from different points of view, hormonal, metabolic, weight, and so on. And we need good wound care and good surgical team, and sometimes laser, and other methods and modalities may help at the beginning and even stop the progression. So JAK inhibitors, like there's no dermatology conference nowadays we go that we don't hear about these drugs. There is a list. They are not very new, like they've been around for hematology and rheumatology probably more than 10 years. And in fact, like 10 years ago, when I gave a talk to, I think it was family doctors at our hospital, for Scarborough, I told them like there was this incidental finding that patients that they were going on ruxolitinib, their hair grew. So that's how they found out that it works for alopecia areata. But now, like as I said, we have a lot of drug targeted for this, and we try to make the side effects less. But these are amazing drugs. Like when it comes, like I can give you a few of examples. Like I had a patient with atopic dermatitis, this girl during COVID. I thought she's gonna end up to psychiatry hospital. Like her eczema was bad. So I gave her first dupilumab. She failed, like she didn't clear. She was crying, each time she was coming to my office. Honestly, I thought maybe she committed suicide. But then I got one of these like JAK inhibitor, upadacitinib, Rinvoq, through like compassionate program for her. And I saw her 2 weeks ago. I couldn't recognize her. She had a big smile. Her skin was clear. And she told me, eczema for her is a distant memory. So when it works well, but we have to have a lot of cautions, like cardiovascular. So I mean, if I have a patient over 65 and there are other options, I wouldn't go to these drugs. For younger patients, we still have to be cautious. They get acne, they get herpes, cold sore. We have to warn them about blood clots. But with the new JAKs that we have, like, it's not the same as tofacitinib, a higher dose of tofacitinib, the chance of blood clot is not as high. Like, the chance is less than a birth control pill. But we still warn them, especially our younger patients, and it's not safe during pregnancy. So for reproductive age, is a bit of challenge. We have to check lipid profile, LFTs, and again, it increased chance of infections. For us, the main condition is serious infections. We are cautious in renal failure, like there are some of them that we have to change their dosing, and malignancy. We still don't have enough data to talk, but apparently the new ones have less, chance, but still something that we don't know. But as I said, a lot of our patients, they're so bad that we want to give them this relief and then decide what to do next. These are some of the mechanisms, like for JAK inhibitors. It is actually more complicated, JAK-STAT pathway. And it's interesting. Sometimes there's a drug that says JAK1 and 2, but when you give it higher dose, it may spill and it can become pan-JAK. So you may have other effects. So, JAK-STAT pathway and all the cytokines, I'm not going over those, but these are the indications in dermatology: alopecia areata, psoriasis, atopic dermatitis, and vitiligo. And we are very excited because for some of these conditions, we never had good drugs, like, for example, vitiligo. So we have selective JAK3 inhibitors, ritlecitinib, that we use it for vitiligo, and there is indication also for alopecia areata. We have, selective JAK1 inhibitors, abrocitinib, upadacitinib, and others, like some of them, they are not available in North America, but they are growing. Like, we're going to have more and more JAKs. But again, like, they are not 100% selective JAK. They have a bit of JAK1, JAK2 selectivity. We have also non-selective or pan-JAK, like the most familiar one is tofacitinib, but there's also baricitinib that gonna get approval for alopecia areata soon. And we have ruxolitinib, which is was available in hematology, and probably it's not as expensive. So some of my colleagues now, you're using it off-label for these conditions, but it doesn't have still on-label approval for it. And there are more, delgocitinib and others coming. We have also TYK2 inhibitor, and the one that we have right now in Canada is called, it's called deucravacitinib, or TYK2. And that's actually an amazing drug. It's an oral drug, very effective for psoriasis, and with some of the side effects of JAK, but it's much safer and the side effects are less. So TYK2 inhibitors, and one of them is called TYK2. Unfortunately, TYK2 didn't get the CADET approval, so it's not an ODB for patients that they don't have drug plan. So some of the drugs that we now use in dermatology, tofacitinib, baricitinib. I mean, I have few patients on alopecia areata. So Lilly, the company, gave compassionate. So generally these companies, maybe it's competition, or maybe they're very generous with giving these drugs. Even biologics, we are so lucky. So if the patients don't have any sort of drug plan, we still can get them coverage for biologics. So there are a lot of compassionate going on, like there are big, huge companies. And so that works for our patients because a lot of patients get the drug. So tofa, baricitinib, upadacitinib, which we call it Rinvoq, Abro, we call it Cibinco, and ruxolitinib, it still doesn't have indication in dermatology approved in Canada, but some we use. Black box warning for JAK inhibitors. There was mainly for rheumatoid arthritis patients, but they talked about heart attack, stroke, cancer, blood clots, serious infections, and death. We don't have that black box warning for Sotyktu, but our patients are all cautious about this. But as I said, like that's mainly for TOFA. When it comes to UPA, like the chance is much less. As I said, Sotyktu is also another one that's effective for psoriasis because the other, like the JAK inhibitors, are oral. I mean, we have some topical going to be approved soon, but they are oral medicines. For biologics, mainly are injections. So a lot of our patients that they want to go on oral medicines, this is a good choice and it works, but it's not very fast and it's not as good as our biologics, but it still works, you know. We used to have omalizumab, but this deucravacitinib, we still have omalizumab, even we have now a generic form of it, like Otezla, we have the generic form of Otezla, was very good for itching, but never impressed us when it came to the clearance of skin. But a lot of patients continue because it was oral. It may work for tendinitis or some of the joints. Sometimes we combined, you know, omalizumab with others, and we used it off-label for other conditions like lichen planus or other conditions like Behçet syndrome or things like that. But now Sotyktu is like omalizumab or Otezla on boost. So it's more effective. It works, but the problem is it still may increase chance of herpes zoster. In my patients, some of them, they got acne and folliculitis. So we still have to warn about serious infection. But with heart attack or blood clots, the chance is not high. There were reports of pericarditis and cholecystitis though. So vitiligo is not a trend. We in every conference we go, we hear about vitiligo, and that's good because this disease for a long time was like an orphan disease. We had probably the treatment that we were offering, even so far we are offering, was the same treatment that I was offering 20 something years ago, like light therapy, topical therapy, maybe antioxidants. But now we have topical JAK inhibitors coming, and oral JAK inhibitor, and combination of that and light therapy can make a difference. So some say, okay, you know, we have models that they go with vitiligo and say it doesn't matter. And I agree, like if people are okay with their skin, no problem. But there's unfortunately a lot of stigma about vitiligo, and culturally some patients, they really get isolated when they get vitiligo. Like in Indian culture, Middle Eastern culture, in certain cultures, it can be pretty bad. You know, people even consider or treat vitiligo patients like leprosy patients. So people may suffer, and children may be bullied. So we are looking for something that really works. And we are hoping that the new treatments that they are coming make difference. There are like basically new and upcoming treatments. So topical JAK, ruxolitinib. I mean, there is upadacitinib or Rinvoq analysis pending. Ritlecitinib, which is JAK3 phase 2 data is coming. We have IL-15 antibodies, and alpha-melanocyte was available, and it's used even for basically some porphyria. I think one speaker a few years ago came, and this was in her talk too. But that's a drug that is just approved for erythropoietic porphyria. It needs to be like surgically inserted under the skin, and a patient using this may turn completely like black, like it changed the color dramatically. So it improves vitiligo. But there was a person that I don't know, somehow used this, like got it. It's for $5,000 or maybe more. Got it. I don't know how, but that white person became black, you know. So that is something that not very practical, like really changes. And if patients like they really have like extensive area of the body involved, we can bleach them. So we can make a black person white, but it's like Michael Jackson, you know. So people lose their identity. So it's very hard, you know, it's a hard decision to do it or not. But sometimes we have to bleach because there are certain areas that just remained colored and the rest of the skin is white. So I just go with one of the cases and then we move on. Is there any questions so far? Sorry, I don't see the questions. So if there's any question, maybe somebody bring to my attention. No questions? So I had a case, 25-year-old man, new immigrant from Sri Lanka. He had psoriasis, extensive psoriasis for many years. He was on methotrexate and cyclosporine, wasn't controlled. He saw another dermatologist, then he came to me, and he was between things that he developed facial palsy, sorry for the typo. And then they started high-dose prednisone, rash got worse, and he was admitted to the hospital. So at the beginning, like it wasn't even a very typical psoriasis, but you see there were some like kind of pustular thing. But when he was admitted, you know, it was very extensive and he was swelling up this few years ago. And honestly, his joints were bad. I thought he gonna die in front of me. He was so bad. So pustular psoriasis can be a challenge. It's an emergency, a medical emergency. They get electrolyte abnormalities. Sometimes potent topical steroid or oral steroid may trigger it. Sometimes they're on edge and they may change, you know. So it requires urgent care. So one of the things and issues is in colored skin, we may not see that pink color. We may not see the typical psoriasis lesion. And I tell you, this is pustular. In previous pictures, you may notice some pustules, but here even looked more crusty. So it's also a challenge when it comes, especially in our patient population, when it comes to diagnosis, you know, because of the type of the skin. Anyway, so at that time, it was a few years ago, so I managed to give him anti-IL-17. At that time, we had Cosentyx, and I mean, he was already on cyclosporine, so he did well, and he's still on biologics, even on, like I saw him a month ago. So his skin is still clear. So generalized pustular psoriasis, it's an emergency. And again, there's a new drug, spesolimab or Spevigo, anti-IL-36. Now it's approved. And it's an amazing drug because it's just one injection and people get clear. So there were like reports of like wondrous syndrome with this, but overall, we hear more and more in our conferences. The challenge is this drug is expensive. It's not in formulary. So when patients are admitted, they need it. But how can we get it? So it's a challenge. But and it's an IV drug like rituximab. They need to go intravenous. But if a patient, and it's not covered still by public, you know, domain. So if like a patient needs it, there are special papers. And if a patient has a private plan, that may get rid of their pustular psoriasis. Pustular psoriasis has a different mechanism than other type of psoriasis. It's more interleukin-36 involved. Sometimes we have palmoplantar pustular psoriasis, which is again different. We have a genetic form of it in kids. I'm not going to go over the detail, but just bring you to your attention a new drug and a new hope. One of the challenges that I've had in Scarborough, I don't know whether Susan John is today here or not. For a few years, I'm just telling, in every conference I'm meeting in dermatology, I'm seeing resistant tinea, not a regular tinea, like very extensive tinea that's not like responding to topical or oral like terbinafine. Tinea that even sometimes doesn't respond to azole drugs. And mostly these patients are from Southeast Asia, especially India, and some like from Middle East, Dubai, especially because of, but there are reports now in North America. There is a form of tinea, trichophyton mentography that they call it endotinea, and there are now reports more and more from North America, but I'm sure we had it in Canada before even US reported, but they were calling it mentography. And those patients, some of them I had to send to Susan John, so she used higher dose of itraconazole, the doses that she uses for systemic, fungus. And even there was a case I asked her whether she's basically eligible for voriconazole, ibuprofen. Like these are challenging cases. So this tinea endotinea, there is a form of epidemic in India. So it's a form of mentography that like it's replacing the trichophyton rubrum that previously was the main thing. And it's also responsible for tinea pedis and onychomycosis. It's very resistant. And guess why? Because, these drugs are available easily and they're given to a lot of patients that they don't have actually tinea. So we human beings, we cause this resistance and it's becoming a challenge. This is a case, my ongoing case. I mean, even I did biopsy on her and it hasn't come back yet. I mean, the original smear was positive for fungus. So you see circles, and this is under her breast, very large area. I got her permission. You see on her stomach. So very extensive, like on hands, like it's not just a one patch of tinea. Any questions so far? So the next challenge that I have almost every day in my practice is prurigo nodularis. Why? Because we deal with a lot of patients on dialysis or chronic kidney condition, and they get prurigo nodularis, but prurigo nodularis can happen in atopic dermatitis or any skin condition. Maybe there is a base, neurologic base, like it's not a uniform disease. But when it comes to the, patients get itchy and it's like a vicious cycle. They scratch themselves, they get itchier, they get these thick papules, nodules, and plaques, and, it's a vicious cycle. So there are, like, so far I had good success with dupilumab, even in my dialysis patients. This is anti-IL-4/13. We use it for atopic dermatitis, very safe biologic. It really doesn't increase chance of infection. Theoretically, maybe some worm and helmintic like infections, but not in reality, Maybe we should give ivermectin to this patient before starting dupilumab. But as I said, in real practice wasn't a challenge. So my patients got well, but some of them, they don't 100% respond. We have a new drug coming called nemolizumab. It's anti-IL-31. I mean, I'm not a clinical trialist, but my friends who tried this, they said it's an amazing drug. Those prurigo nodularis cases, they melt. I'm going to an ad board like soon, next week, and hear more about this. But this is something we are excited to see and hopefully fit in and improve these patients, because these are really, really challenging patients. And so far, like before these drugs coming, we were injecting Kenalog, we were giving a lot of immunosuppressant, using light therapy, giving prednisone, and sometimes with success, sometimes with not any success, like naltrexone, gabapentin, Lyrica, topical menthol, topical capsaicin, you name it. But when you have a huge list of drugs, we know that there's none of them working well, So there's this also drug, diphenhydramine, works on Mu receptor, we have kappa on Mu receptor, and we were very, we were hoping that this drug get cadet approval and be on ODB, but they couldn't. And the reality is, a couple of my patients that they were started on that, they got 30-40% better. They were not clear. And this is an IV drug after hemodialysis or at the time of hemodialysis, mainly made for itching of uremic itch for hemodialysis patients. It's available, Katsura, but I think the name is Katsura, like the brand name. But as I said, not for the public, it's just for private patients now. So as I talked, we have new topicals, we have like a drug, topical JAK for vitiligo. It's been available in US for a year or so, and we hear good results, but it's not fast, it's slow. And if we combine it with light therapy, probably we're gonna get better results. We have also a very interesting new topical that we are very excited, and it's been around for a month or so. And that's a topical anti-androgen called Winlevi or clascoterone. We use it for acne. We can use it for women and men, because if we don't have androgen, we won't have acne. So it doesn't have any effect on hair, like it doesn't work on hirsutism. It's mainly for acne, but there are many studies coming that it also has some effect for HS. So it's a new topical that we have in our armamentarium, and we are using it whenever we have a new topical. We use it a lot. We also have this topical PD4. We used to have Eucrisa, we still have. It wasn't as effective, but roflumilast is an amazing drug. Like the indication is mainly for psoriasis, but we use it for eczema, vitiligo, and off-label for other things. There are other drugs with different mechanisms are coming, topical taperinov, for example, but that is not available in Canada yet, although it was originally discovered and made in British Columbia, but it was approved in US first. The roflumilast also, besides psoriasis, like there's a foam form of it that is coming for seborrheic dermatitis. And these are honestly very safe drugs. They are okay to use on face, folds, it doesn't thin out the skin. They are not steroid, and again, and they don't cause itching or problems. Sometimes huge amount of it may cause diarrhea, like omalizumab or Otezla sometimes was causing diarrhea too. But so far, none of my patients complained of this. So as I said, Winlevi is topical androgen receptor inhibitor. It's a new cream that we have. It's FDA approved 2020, and it's been in US for 2 years. It has to be used twice daily. Mainly we use it for face or areas that we see more androgen-related acne. I'm using it in HS patient as an adjuvant, but it's kind of a bit new, so we are still, but it has a very nice moisturizer effect. So I combine it also with Retin-A for acne, and patients like it because it has that effect, the moisturizer effect. So I'm done with the serious presentation. Now I'm gonna go with some cases, if it is okay. Any questions so far? So this is a man, 60-year-old man, Chinese descent. He came to my office. This is one part of his body. So if you look, you say, oh, maybe it's eczema, maybe it's psoriasis. But this is the other side. So that's a case of mycosis fungoides or CTCL. I had a dermatology resident with me, and honestly, despite he was familiar with this condition, he said, now I know what they call it, fungoides. He had stage 4 from the beginning, so we sent him to Odette. He lasted few years, but he passed away, unfortunately. I'm kind of like defending our profession, that dermatologists are not just glorious esthetician. That's what we are called, glorious esthetician. But these are things that I'm seeing on everyday basis. And this is something that, I mean, should have been basically found out at this stage. Then we could have saved this patient, you know, but unfortunately he died. This is another case that we have over 30 of them right now recorded in our hospital. We had a bit of problem to publish it. I don't know why ethics committee gives troubles, like despite it was just retrospective publication. We have over 30 patients of this condition. It's very painful. It's called calciphylaxis. Last year, I gave a round about calciphylaxis. So previously, like if you look at the records, they say there's 80% chance of death. But in our hospital, 80% survived. We still had some mortality, you know. So if we diagnose this condition earlier, if we treat it earlier, we can save it. And this is one of those conditions we really don't want to debride to the bone, you know. So if you give it to any plastic surgeon, they're going to debride it to the bone, but with Kepnerization, actually, they make it worse. So we need a gentle debridement of this scar and a lot of wound healing thing, but we use sodium thiosulfate. We used to do like for 4 or 5 years, Dr. Sikanata and I, every week we were going to the hospital and injecting these patients until COVID. And then thanks God, it was approved by CADET, and now it's approved through a special, you know, program. So they get it after, like with dialysis IV, although the side effects are a bit higher, but the pain is less when, like when we do intralesional, they're more painful. But so we have a treatment for it. And it's interestingly, when patients survive, it doesn't affect their overall mortality. So this is that patient that improved, and interestingly, she survived and she's still going on. This is another interesting case. Anybody knows what this is? Of course you know, but anybody wants to shout it out? So this is a patient with melanoma. But the reason I brought this, I was in a meeting 2 weeks ago, and there's a researcher from Montreal, and he was talking about suntan and sun exposure releases endorphins. So people, it's like an addiction. So this lady had covered her melanoma for many, many months, and who knows, maybe a year. And she was going for tanning. Probably she was aware of it, that this is melanoma. But you see how her skin, like she had a Band-Aid on it, and she was still going for tanning. So it's just an example. I mean, when at this stage, it was stage 3, so definitely increased her risk. So, but definitely we see more melanoma, and especially in women, the rates are increasing, or maybe we are picking up melanoma at earlier stage. But despite all the warnings, still like the sun exposure, tanning, and intermittent sun exposure is something that's happening in our community. This is another case from hospital. Again, I got her permission. Even she came back to my office after she survived. I should have taken a photo with her, because this wasn't her face when I saw her back. This is a very swollen face, you know. This patient was on one of antipsychiatric medicines and developed this rash. So you see a dusky rash, atypical target lesions, some blisters, and if you rub the skin, it's gonna tear off, like Nikolsky sign. And you see severe conjunctivitis and involvement of the eye. She survived. Her eyes were okay. Like we treated her in our ICU and then transferred her to Sunnybrook. But thanks God, she survived without any sequela. So this is Steven Johnson, or TN, something that I never finish any talk, especially for our hospital doctors, without touching base on this. I was attending a meeting on the severe cutaneous drug reactions a few weeks ago, and some of the experts were there. Still, we still treat with cyclosporine. And I know there's resistance from ICU doctors, but I mean, the consequence of sometimes not treating these patients is blindness if they survive. And that's definitely a huge morbidity. I mean, there are a lot of interesting things online. There are societies that they talk about it. Like there were a few online things about DRESS syndrome, like parents of patients that they lost their children. So like one on Septra, one on the other thing. So it's good to look at it. And I mean, they say it's really, really rare, but if it happens, it can happen to any prescriber, and it's gonna affect your life forever, because if you lose one of these patients, that's something that, it's gonna haunt us. And we have severe cutaneous adverse drug reaction, DRESS, Stevens-Johnson, and AJAP, acute generalized exanthemus pustulosis. So generally for Stevens-Johnson, we have a mnemonic Satan, like Septra, sulfasalazine, allopurinol, tetracyclines, minocycline. I rarely prescribe minocycline for this reason. Allopurinol, two or three of our patients that we lost in our hospital, they were on allopurinol. So it's serious, So if somebody is a prescriber, has to be aware of this. And there are other drugs. Like I had 2 patients here on lamotrigine. During the time I was covering hospital, we had 12 or 13 patients, and 3 of them died. One was 2 of them, they called me very late. One was DRESS syndrome, one was Stevens-Johnson, and the third one was a very sick patient, dialysis and everything, So there are HLA. I think these HLAs should be covered, but unfortunately they are not. So patients have to pay unless they do it at the hospital. So we see more reaction with allopurinol in Han Chinese, but it can happen in a lot of ethnicities. In fact, one patient of us that died was Filipino, the other one was Black Jamaican. But, there are a lot of mixed, ethnicities, and it's not just exclusively Han Chinese. Carbamazepine, we had one patient on carbamazepine in ICU. I had one patient during COVID, like at the time that vaccine was not available, and patient had COVID and it was on antibiotics. And remind you, 20% of time we don't find the reason. Like Alexis and I, we shared a patient and we didn't know what caused it.
Maury?
Yes.
Question about this type of reaction. Is it idiosyncratic? Like, is it, if someone's been on it for like the medication, those medications for like a year, 2 years, 3 years, can it still occur, or is it usually early on?
Yeah, it's basically type 4 reaction. So it's not something that happens right away, but it may take 3 weeks to even 6 months. It's very rare to see that reaction later, but it has to build up. So that patient on antipsychotic medication was on a depot drug. So because it was like monthly, so it happened later. But theoretically, I have to tell you, no, it doesn't happen when a patient is on that drug for a long time. But there was a question, like about one of the patients was on trade form of carbamazepine, then switched to generic and developed a reaction. I actually asked Dr. Shear and he said no, but as I said, there are times that we don't know exactly what is causing Stevens-Johnson. So it may not be the actual drug. We have patients that they go and get glutathione to make their skin lighter for beauty, because Bollywood actresses, they did. Glutathione may cause Stevens-Johnson. Vitamin Bs, like IV injection of vitamin Bs may cause, so there are other things that may cause. And if you look at the list, is very it's huge. I had a patient that was on Crestor. Like I was during residency and actually taking care of that patient. And that patient, I think, died in Sunnybrook, and he was on Crestor. So the list is long. But yes, if a patient is on allopurinol for a year, it's less risky to be cause of this.
Maury,
weeks, 6 months.
I was just going to add, yeah, that case that we had, I remember very clearly. And I think the ultimate question was it the venlafaxine, but she'd been on it for years. So it was never totally clear.
Yeah, so I mean, I generally ask at the end drug safety clinic. Now we have a drug safety clinic, I guess, in our hospital. So it's a good question to ask our allergist, but not necessarily always we find the cause, you know. I have like this doubt that maybe drugs over time may also cause that, but you know, if you want the answer based on the book, no. And I mean, I have like this cocktail, but there were some studies that showed maybe if we use IV, like we had a lot of doubts and debates about IV, like methylprednisone, give it or not. At some point say no, then they said yes. Now they say it may increase a bit chance of complications, but cyclosporin still comes on the top. Then it comes to Enbrel, and it's, thanks God, it's in our formulary, or other anti-TNF. You really want to stop that cascade of cytokines as soon as possible. And if you do even stop the drug, you know, conservative treatment, you know, check the patient. We had one patient on Septra. So one of our hospitalists called me. So I went to the, before even I did, like, he sent me a photo in the morning, and so sorry, there's this alert. So then I saw the patient in the afternoon. By that time was 10 times worse, and we knew it's developing and evolving. So we started cyclosporin right away, stopped Septra, and then honestly, that patient went home in 2 days before even going to ICU. So if we recognize it and start the treatment, we may stop progression. And also know the plausible drugs. Like if you're a prescriber and patient is on one of those drugs, you know, be more cautious and watch them closely at the beginning, you know. Yeah, and be careful of the eyes, you know, cover all your bases because we may be sued. So this is a case right now is in the hospital. I just actually, before this meeting, I was talking to Dr. Fong. This is a patient with IBD. I got his permission yesterday. These are, ulcers on the back of his neck. You see, this is his ear, huge ulcers. This is on his chest, in the middle of his chest. This is the forehead. You see his nose. So, I mean, the biopsy is still pending, but it looks like pyoderma gangrenosum. He has IBD. This is a poor guy with a lot of, he had resistant to a lot of drugs for IBD. He didn't respond. Again, the point is, don't debride to the bone. I know I'm not there doing consults anymore. I know generally plastic surgeons do this consults and they do biopsy, and we are very thankful that they do it. But honestly, for these conditions, debridement to the bone doesn't help. This is not necrotizing fasciitis. It may actually make, the capnirization may induce and may make the wound larger. And it's very hard to heal this wound, you know. So what can we do for pyoderma gangrenosum? There are some studies that say that pozolimab may work, but we generally go with, it's not necessarily parallel to the IBD, but we treat also the underlying condition. I mean, prednisone, intralesional, oral, immunosuppressant, methotrexate, Imuran. We have some studies for JAK inhibitors. We have anti-TNF, that we have also antibiotics, Dapsone, Septra. But we have studies that pozolimab anti-IL-36 may help, but that's a $10,000 drug, and I'm not sure I can get it off label for him. But if we can, maybe that helps to heal this. Sorry. One more patient. That's a patient with pemphigus. Again, it's a challenging disease. I had it few days ago. I just show you cases that I've seen in the last few months. This is another patient that's bullous pemphigoid. We know bullous pemphigoid is related to gliptins. Not caused necessarily, we see also more in patients on dialysis, but if a patient has bullous pemphigoid, is on Trajenta or Januvia, it's a good idea to stop it. I mean, before this meeting, I was talking to Dr. Tink. This patient is right now in ICU because I gave immunosuppressant Myfortic, and he was like, his skin cleared or better, but he developed like right now, sepsis and bacteremia. So he's in ICU and his white blood count dropped. So these are actually, maybe there's every day that goes by, I have 2 or 3 of these bullous pemphigoid cases. This is another case that was a challenging case. Looks like bullous pemphigoid, but that was hemorrhagic vasculitis. So bullous vasculitis. And this patient, like the other patient, was also diabetic. This one is also diabetic. Huge challenge. I started him on Dapsone, but he's not compliant. I never see any blood work. I want to make sure he has methemoglobinemia or not. He doesn't do blood work. He doesn't, when he comes, he has that attitude to my office that he's always angry, although his skin is cleared. So it's very hard and challenging to deal with these cases. I think I'm almost done. And that's a patient with HS. And again, every day I have 2 or 3 of these cases. And that's also something that we really need multidisciplinary. Thank you very much. Sorry. I mean, in the middle, I ask if there are any questions, but if there is any question, I stay and answer your questions. Okay.
Oh, can I ask one question?
You can ask 2. I'm here. Don't worry.
Thank you so much. It's so informative. I joined late. I'm sorry, something busy there. Maybe you already introduced, I missed that part. For Birchmont side, how can we get access to you? How can we send the consultation for our patient here?
So the problem is, and don't get me wrong, Alexis is working hard on it. Elaine is working hard. When we had, like for 10 years, I was covering Scarborough Hospital alone. But now we have 3 hospitals, and a lot of hospitals, they have my name and my email. I can't cover 3 hospitals at the same time when I'm seeing 50 to 60 patients a day.
Yes,
That's impossible. And that's basically a national problem right now, because probably the whole country, we have about 300 dermatologists that they're really prescribing real drugs. But how many hospitals do we have in the country? I'm sure that we have 10 times more, like maybe 3,000 hospitals and 300 dermatologists. So we have to come up with something like a plan, and it has to be a bit through the healthcare. Like I was thinking, for this Steven Johnson or TN, like that pyoderma gangrenosome, I saw that patient in my office. Yes, of course, it was like domino effect, put me an hour behind. But I mean, I'm trying, like, for patients that I can bring to my office as much as I can, and we are trying to make a clinic for multidisciplinary cases in our hospital to have these things together, like the way that specialty clinic is. So we are working on it. But I mean, the reality is sending like a dermatologist to 3 hospitals at the same time, it's a full-time job. So is there any alternative plan to pay these dermatologists, younger dermatologists? I'm not sure. It's not in my level, but we are trying, to make ourselves accessible. I mean, I'm at my office. If you have any urgent case, feel free to contact me or call my office, say urgent. As much as I can, I try to accommodate, or at least I try to make myself available. But even medical legally, imagine like this patient on Myfortic, I know, like I saw him less than 3 weeks ago. He was okay. Now his white blood can't drop to 0.1, and he's in ICU with sepsis, So even if we can't make a recommendation, we have to be there, So these are not easy cases. These are really internal medicine cases, but they need a bit of like not a bit. They need a dermatologist that knows how to do the inpatient consults. So maybe we need a team like stroke team for Steven Johnson and Tian, you know, like a team that throughout the country, they make themselves kind of available. If even not us, maybe some GPs that they have interest in dermatology to work with us, or physician assistant, like to fill up the gap, you know. So if somebody does biopsy and they tell me this is like a biopsy is done and this is it, so I can actually lead through, you know, but I can't be at the same time in 3 hospitals.
Maybe, okay, let me introduce myself 1 minute. I'm the new hired wound care nurse at Birchmount site. Maybe I'm looking for some opportunity to shadow in your clinic, get awareness, because understand it, people are thinking, okay, there's skin, there's wounds, always come to me. But for me, my knowledge is limited. I need this kind of special support there.
Thanks for doing this. Like wound care is the whole new era. Like I'm not claiming I'm a wound specialist, but I have to deal with wounds. And some of my colleagues, like dermatologists, say, "Why do you do this?" I say, "You know why? Because if I don't do any, nobody else accept." Like these are generally patients that they've seen other specialties, generally sent to me through wound care clinic from plastic surgery or from other parts. Like, you're welcome. I mean, my clinic is, the pace is crazy, and it's a very small office with sometimes
I will.
residents.
Really
I mean,
excited, and we'll look for some opportunity there. Thank you so much.
thank you. Thank you very much. Any other questions or comments or?
Thanks so much, Maury, for sharing this. It's a great asset for all of us to see these cases and to hear these updates. Really appreciate it.
Thank you, Alexis. I tried because, you know, I feel it's not fair. You know, these are very specialized drugs, but let's say a patient comes with, you know, like with IBD and comes to the basically emergency and is on anti-IL-17. If nobody has any idea that can be cause, you know, then how can people make comment, you know, or, you know, like about some of the specific side effects of JAK inhibitors, like people can get bad acne, herpes, you know, and we see it and it's real, you know. So I thought it's a good idea to just discuss for overall our hospitalists, but hopefully it was helpful.
Thank you, Dr. Hassami. This is Quentin here, the allergist. That's such a great talk.
How can we access you? And do you accept my drug reaction patients? Can you put your information in the chat box?
We actually had a chat with our leadership team. Currently, we can only access for assessment of antibiotic-related drug reactions because we just don't have the same. We don't have enough fundings and resources for having a full scope. However, Sunnybrook right now, they are open up for referrals, and because they just hired a new allergist there, so they would have full access for a full scope of practice for chemo agents or some of the antipsychotic agents. So I think this is also an opportunity to let everybody know. I guess the second point is about you talking about the Steven Johnson and 10. I 100% agree with you that it doesn't have to be cost by drug. Number two is that even the cost by drug, when they come to you or us, often there's nothing else we can offer, right? So just avoid these drugs, right? But it's the moment where they have the acute, clinical manifestations that 50% of mortality in ICU, that's a critical time to intervene. So I think maybe we should develop some sort of systems so that, because we have to acknowledge that most of our colleagues are not trained to understand the biologics, or those things.
To be honest, our hospitalists are doing a great job, and even
Right.
emergency doctors and ICU. I think the awareness is part of it, but I 100% agree with you. I was talking to one of my colleagues, and I mean, this is the bottom line. It's a dermatologist that he's now in news and CBC and said, you know, if one patient dies of Steven Johnson that we could have saved, we are all ashamed of it. We should have a system to save these patients, you know, at least when we are present or in our presence, you know. But I mean, the challenge, as I said, shortage of dermatologists, there is a crisis. There's not enough dermatologists. And I mean, we have to battle and find a way. I'm sure, like, I mean, they actually offered me in our organization to take some responsibility because I have passion for this, but single-handedly, nobody can do it. We have to make a system. I agree with you 100%, but we have great physicians in our hospital, and generally they pick up this fast. And even through the phone, like, I mean, biopsy is not the critical thing, and biopsy not going to come tomorrow, you know, even if we pull the strings. So first is the diagnosis and start right away. Biopsy can be done by anyone, you know. I can teach any hospitalist how to do biopsy, or plastic surgeons, or a resident. That's not a big deal.
I completely agree with you on that aspect as well, because I think by my experience, often colleagues resistant to start treatment, number one, that they feel like there's no biopsy result. But when it comes to Steven Johnson and 10, that's very obvious if they have it or not. Number two is that, you know, often people talk about, you know, you can put them on immunosuppressant, cyclosporin, would it be worried about the TB, all that kind of stuff. I was like, when it comes to that kind of mortality risk, there's no, we're not worried about TB. We just have to treat them to prevent from progression. So if you want, I'm happy to be part of a team. We can probably develop something just for our colleagues so that they'll feel more confident when it comes to like some sort of like pre-order set or something. Like so when they suspect, as long as there's consent from patient, I don't think that treatment should be delayed. I agree with you. We have great colleagues too.
Yeah, definitely. And everybody works hard, and for sure, like, everybody cares. And again, thank you for attending this round. Sorry it took a bit longer, but yeah, so I mean, and I didn't even touch base on all the new targeted therapy reactions on chemotherapy and, you know, things that I see with targeted therapies, and, you know, but we can talk about that maybe in another session if people are interested. And thanks to like all the support from the hospital. So I let you guys know, unless there is any burning question, I can stay a few more minutes. Thank you. Thanks, everyone.
Thank you.
Thank you. Bye.